Hey guys, welcome to chapter 3. In this chapter, we're going to be talking about assessment and diagnosis. So broadly speaking, this chapter is going to focus on the process of determining whether or not a behavior that a patient or a client is exhibiting is abnormal. And we're going to do that through a process of assessment, that is gathering data, and then deciding on the basis of that data whether or not a diagnosis is warranted. So the goal of assessment, broadly speaking, is to, as I mentioned before, gather information about a person. Generally, the assessment process starts off with a series of referral questions, meaning that the individual themselves is coming in asking something like, do I have ADHD? Or is my grief normal, or do I have depression? Or alternatively, the person may be referred to us by another professional, whether that be a teacher or another provider, or even a parent. And in that case, that individual might be asking the question. But either way, generally speaking, we have a direction that we're headed in, and we're not assessing them for literally everything within the DSM. The first step in any assessment process is to begin with a screener. And the purpose of a screening is to determine whether additional assessment is needed. So rather than sitting down and breaking out the full diagnostic criteria for something like major depressive disorder, we would instead ask a few quick questions to determine whether or not it's even worthwhile asking additional questions. For instance, if we were to ask a client, are you feeling sad or are you feeling anhedonic? And they said no to those things, we can move on from asking further questions about depression, because those things are critical to depression. And so if those things aren't present, we don't need to ask any additional questions. We can just move on to asking questions about something else. A more medical example might be something like when you go to the doctor and you typically will have your blood pressure, your blood oxygenation, your heart rate, your respiration rate, your weight, things like that measured. These are screeners. If all of these things look good, then most typically a person won't proceed with additional assessment. But if one of these things is coming back abnormal, then that might be reason to consider more serious medical problems. Just because a screener comes back positive does not mean that a more serious problem is present. It just means that further assessment is needed. So just because your blood pressure is a little high doesn't mean that you have hypertension. It just means that we want to follow up. Similarly, if in a mental health setting, a patient says that they are feeling sad, that doesn't automatically mean that they are depressed, but it means that we need to ask additional questions. Good screening tools are both sensitive and specific. Sensitive means that the test is accurately suggesting the diagnosis when the diagnosis is present. So the person is depressed and the tool is saying, yes, this person is depressed. Specificity is accurately suggesting the diagnosis is absent when in fact it is. So the test telling us this person is not depressed when in fact they are not depressed. What we want to avoid, obviously, with screeners are false negatives and false positives. False negatives being when the test suggests the client is depressed, but the client is not. False negative being when the test suggests there is no depression, but in fact the client is depressed. There are several different types of screenings, and I'll show you guys a couple different more examples in class. But for now, these are just some things to consider. I verbally kind of talked you through what a depression screening might look like on the previous slide. That example that I gave you of asking the client whether they're sad, feeling down, and whether or not they're anhedonic, meaning that they have little interest or pleasure in enjoying things normally. These are critical symptoms that are necessary for a diagnosis of major depression. A client must be experiencing one of these two things at least, in addition to other symptoms, in order to be diagnosed. And so if a client doesn't have either of these things, we can move on to ask about other symptoms. And if they have one or more of these symptoms, again, doesn't mean that they automatically have depression, but it does mean that we need to ask more questions. The second example is an alcohol use example. This example is asking about the focal behavior and then key problems associated with that behavior. So, do you drink alcohol would be a good screener for alcohol use. If the person doesn't drink, then you don't need to ask further questions. If they do, you can ask follow-up questions about binge episodes or blackouts, key problems associated with alcohol. And again, if those are there, doesn't necessarily mean an alcohol use problem, but it would be reason to move forward. And these questions come to us from an alcohol use screener called the audit. So once we've done our screener, or a series of screeners, we know what assessments to kind of follow through with. So any screener that comes back positive, we know, okay, now we need to ask more questions in this area, that area, and this area as well. And so that's when we move on to the second step of assessment, which is choosing more extensive assessment measures. And there are several different to choose from. Broadly speaking, we have interview, personality, symptom-based, cognitive, behavioral, and physiological types of modalities. Interview is what it sounds like. You are interviewing a person, sitting down, having a conversation to figure out what's going on in greater detail. Generally speaking, there are a couple different ways to structure an interview. An interview can be highly structured, in which case you have a precise list of questions that you're working through, and you are asking those questions in that order, verbatim, reading from a script. Unstructured would be you're just kind of rolling into the conversation. You have an idea as to what it is you need to ask more about, but you might not have a specific prompt in front of you. And then semi-structured is somewhere in the middle where you have some idea as to what you're going to talk about. You might even have a list of symptoms that you want to cover or a list of topics that you want to cover, but you haven't written out specific questions that you're going to ask verbatim. So it's somewhere in between the unstructured and the structured. There are pros and cons to each approach. As you might imagine, the structured can feel a little robotic and clinical, which is a setback. But a benefit of this approach is you know that you're giving the exact same interview every single time you use this measure. Unstructured, the pros and cons are really reversed. It's nice because with unstructured, you can be a little bit more informal. You can be yourself. You can cater your word choice and your cadence to the energy that the client is bringing into the room. But the main setback is that without any structure, you might miss something, or even if you cover all your bases, this is not the same assessment every single time that you give it. And so patients and clients are getting different experiences just on the basis of where you are and what you choose to ask on a given day. Semi-structured is my favorite. That's the one that I use most frequently, where I have kind of a general plan, but it's not so written out in terms of what exactly I'm going to say. And that's nice because it capitalizes on the benefits of both. It allows you to kind of move around a little bit more in terms of your approach, the energy that you have, the word choice that you use, even the ordering of questions, but you still have something in front of you reminding you to kind of hit all of these key points in each and every interview. Personality-based assessments can be either clinical or non-clinical in nature. A clinically based personality assessment is aimed at determining whether or not a person has a personality disorder, whereas a non-clinical personality assessment is aimed more so at determining just general personality features. So how extroverted are you? How introverted are you? How conscientious are you? Things like that. Things that are interesting to know about an individual, but aren't necessarily relating to a particular diagnosis or not. Probably the only non-clinical personality measure I use is a measure of perfectionism. Perfectionism doesn't directly relate to any of the personality disorders, although there are some links, but perfectionism can definitely manifest in a variety of ways, and then can impact a variety of diagnoses, things like eating disorders, obsessive compulsive disorders. And so sometimes I'll assess personality in a non-clinical way. And generally speaking, in doing either the clinical or the non-clinical types of symptoms, types of personality traits, we can ask questions or interview a client in either a projective way or more of a survey type of fashion. A projective is when you are not asking the person directly about their personality, but instead you are asking them to do a seemingly unrelated task, like explain what an ink blot looks like, or draw a house, a tree, and a person. And then the assumption there is that the person is projecting their personality onto that task, hence the name, and that you then as the clinician are going to be responsible for picking apart their personality on the basis of that exercise. This is a very psychoanalytic approach, and understandably there is much less empiric support for this particular approach, just because so much more of it is subjective. And we'll talk about these approaches a little bit more later, and more specifically why they aren't always great approaches to use. The survey method is a more direct method. It is what it sounds like. It is, you are asking questions like, do you enjoy socializing with others? Do you find yourself overwhelmed by crowds? Very direct survey-based questions. Symptom-based assessments are where we are going to be assessing either the person's general functioning or more specific symptoms. So we might give them a survey, kind of like the survey personality type that I talked about earlier, but instead of talking about personality traits, we're either talking about specific symptoms or more general symptoms, or indicators of general functioning, like are you able to get to work or school? Are you able to socialize? Taking stock of how specific symptoms are impacting their larger life in general. Cognitive approaches can also be general or more specific. If we're doing a more general approach to a cognitive assessment, this would be something like assessing general IQ, like the big overarching measure of intelligence that we most commonly use in the United States. Alternatively, we can also assess for more specific domains of cognition. So we could assess for memory, processing speed, creativity, kind of smaller factors that exist under the broad general domain of IQ. And on the far side of the screen, I have some examples of different types of questions that feed into general IQ, just to kind of give you an idea as to what types of things impact intelligence. So there are questions pertaining to vocabulary, general information, mathematics, comprehension, which is an interesting category. So that includes questions like, why do people buy fire insurance? This isn't something you would be taught in a formal kind of educational setting, but it's assessing whether or not you've been able to pick up on more life type of skills, street skills, things like that. There's typically also memory tasks like digit span, where you'll be asked to reiterate a series of numbers. There may also be visual spatial exercises where you might be working with blocks or different things of that nature. Behavioral assessments are not survey in nature. Instead, they are observational. So either you as the provider or potentially someone else, you might have a parent or a teacher fill out an observational item or measure for you, or sometimes you might even have the clients self-monitor themselves. But either way, we're not kind of reflecting on traits or symptoms, but we are assessing behaviors that are happening right now. So again, you can do this via self-monitoring, where an individual is maybe filling out like a sleep diary or a substance use calendar. You can have a teacher or a parent fill out a measure reflecting on the client, or you can observe yourself. Typically, observations are only done really with kids, I would say, and more so in a school setting. So sometimes more of a child psychologist or school-based psychologist might go to a classroom and observe a child in a natural setting and do kind of like an ABA breakdown of behaviors based on what it is they're observing. And then finally, we may also do physiological assessments. These are going to be measures of physiological functions, like we might do an EEG in order to observe sleep patterns and diagnose sleep disorders. The major function of all of these assessment measures, whichever are used, is to diagnose. And typically through the process of diagnosing, we're going through a differential diagnosis, which is the process of narrowing the full DSM down to a handful of options in terms of what might be going on with this person. And then we're eliminating it down further to what the actual diagnoses are. Typically, the goal with diagnosis is to give the person the fewest number of diagnoses possible while making sure those diagnoses are still appropriate. So one thing you'll realize as we start getting into diagnoses is that there is a lot of symptom overlap across diagnoses sometimes. And we don't want to simply give a person 2 labels because they technically meet criteria for both disorders, but that either label would describe what's going on with the person just fine. We want to make sure that we're only assigning secondary and tertiary diagnoses because they're explaining additional pieces of what's going on. So for example, if I had a patient who was meeting criteria for major depression and generalized anxiety disorder, which share a lot of symptoms in common, and they happen to have that clumping of symptoms that is shared by both disorders, what I would do in that scenario is I would think more about which is the best explanation for what's going on, and I would assign only that diagnosis, unless it happened to be a scenario where I felt like either diagnosis alone didn't fully explain what was going on, and it was truly necessary to include both for the purpose of holistically describing the individual. And I'll show you guys some examples in class of assessment measures and kind of how a differential might end up looking. The final step in terms of assessment is outcome evaluation. This is technically an optional step, and it's a step that you would really only use if you were also treating the individual. So some providers specialize specifically in assessment. So their job is to see people, administer screeners and more extensive assessments, figure out what the diagnosis is, and then refer out for treatment. Some folks exclusively do treatment, and some people kind of do the whole gamut. It just kind of depends on what your specialization is and what the scope of your practice is. But this third step would be a step you would be doing if you were diagnosing and then also treating. The aim of an outcome evaluation is to indicate whether a client is improving or deteriorating, or possibly whether treatment is over or needs to be changed. So despite the name outcome evaluation indicating that this is something you might do at the end of treatment, you actually want to start doing this at the beginning of treatment. That way we have a baseline and something to compare to as we move through treatment to determine, okay, are symptoms reducing? Are they going up? Are they staying the same? Do we need to continue with what we're doing? Do we need to mix it up? Is this person ready to graduate from therapy or not? Most commonly, outcome evaluations are going to assess symptoms to monitor whether or not a person is still meeting criteria for a disorder. But I also like to include items that are assessing life satisfaction, quality of life, just general distress and impairment, because as I said earlier, in my chapter 1 talk, that really is the most important thing, is the individual's quality of life. So if their symptoms go down, but distress is still high, life satisfaction is still poor, quality of life is still poor, I still want to work on those things, even if the symptoms have improved. In terms of assessing whether symptoms are significant or severe or not, we might reference statistical or clinical significance to judge whether or not symptoms are significant or not, whether they're improving or getting worse. Statistical significance would be looking at the number of symptoms that average folks with a particular diagnosis have. So we might use, let's say we're working with someone who has major depression, and we're using a depression measure, something like the Depression, Anxiety, and Stress Scale or the Beck Depression Inventory. We might reference what's considered high, what's considered low, what's considered normal on that measure, and we might consider the person to be improved when they move from one category of severity to another. So when a person moves from a very high level of depression according to that measure to a high level. So as they move categories, that's statistically significant improvement. Clinically significant is a little bit more subjective. It's, are we still meeting criteria or not? It's, based on knowing the client, maybe sleep is the thing that is really bothering them. It's the worst symptom. They have other depressive symptoms as well, but the fact that they're experiencing insomnia is absolutely the worst. And you're finally able to help them sleep in a more healthful way, sleep through the night without waking up frequently, without it taking forever to fall asleep. And they still have other symptoms of depression, but because of the subjective significance of that one symptom, we might judge that to be a clinically significant improvement because quality of life has improved so much with just the treating of that one symptom. So there might be other symptoms there, but that still is a clinically significant change. Again, even with other symptoms being there. So those are generally the ways that we gauge whether or not we are improving. And again, as I mentioned before, despite the name, this is something that we want to use definitely at the beginning of treatment, but we also want to use it throughout too, not just at the end, to kind of gauge how a person is improving throughout treatment. We also want to be consistent, so you wouldn't want to use like the depression, anxiety, and stress scale the very first session, and then the Beck Depression Inventory, and then something else. You want to pick one and use it consistently. And I will show you guys examples of this stuff later on as well. So those are the 3 steps of assessment. So we've got screening, the more extensive assessment process, and then the outcome evaluation. So the next thing that we're going to talk about as far as assessment goes is how to choose assessments, what makes a good assessment and a poor assessment. And there are 3 different things that we need to reference in making this determination. One is that measure standardized? 2 is it reliable? And 3 is it valid? So to be standardized means that an assessment has been given previously, so we know what is high, low, normal, etc., by making comparison to old data. So for example, if I generated the DASS, the Depression, Anxiety, and Stress Scale that I mentioned on the previous slide, before I went out into the field and started giving it to patients, I would first need to give it to a group of people to see how people score on average, what's a high score, what's a low score. That way, when I give it to my client later, I can compare their score to this more normative population series of scores, and I know whether a score is, again, high, low, normal, etc. And that's what's called a normative comparison, when we compare an individual's single isolated score to a sample from the population. It's important that we make sure when we are administering this assessment to this group to determine, again, high, low, normal, etc., that we are giving that measure to a representative group of the population, so that then when we give it to clients going forward, we know that those clients were represented in that initial population. So you wouldn't want to give a measure to a bunch of college students, for instance, and then roll into a Veterans Administration or a retirement home and use it there, because you didn't normalize that measure on that population. You normalized it on a completely different population. So we want to make sure that populations that are used are normative. A self-referent comparison is when we give the assessment to an individual client multiple times over a period of time so that we can compare their score to their previous scores. So if we were doing outcome evaluation, for instance, and we were giving them the DASS every week for 3 months, we could not only compare a score to that normative population, but we could also compare that individual score to their past scores to determine how good or bad they're doing relative to their past history. So that's what's called a self-referent comparison. As far as reliability and validity goes, these are complementary features, I guess, of diagnosis. Reliability is how consistent a measure is. Validity is how accurate a measure is. So for reliability, we're interested in whether or not a measure is producing the same result again and again. So we want to make sure that if we give the same measure in the same circumstances repeatedly, we're getting the same result. Otherwise, it's not really doing us any good. Some ways that we will assess this are the test retest, which is what I just indicated. We give the test multiple times in the same situation to see if we get the same answer. Inter-rater reliability is another way to assess reliability, where we give the test once and then we have multiple scorers score the assessment. If the assessment is reliable, it's been written well, the grading instructions are clear, multiple people should be able to look at the data and arrive at the same answer, the same conclusion. So this is where projective personality tests have a lot of problems, because if I asked one of you guys to draw a house, a tree, and a person, and then I asked the rest of the class to write down, what they thought your drawing skills said about your personality, I would likely get 30 some different responses. And even if I brought in the rest of the psych department, the rest of the clinicians in the department, and even if we were all trained in projectives, we would likely be arriving at very different answers. Or if we gave the test multiple times, if we had the same person take the house, tree, person test, once a week for several weeks, we would likely be getting slightly different drawings, slightly different results. Same thing with something like the Rorschach. You would get slightly different interpretations each time you used it. And so one of the reasons that projectives are advised against is because they have really poor reliability. As far as validity goes, this is going to be the accuracy of the measure. So it's not just important that we get the same result again and again. We want to make sure that we're getting the right result. So we're not just kind of getting a clustering on a bullseye, so to speak, but that we're getting a clustering of shots at the center of the bullseye. Sometimes things are reliable, but they're not valid. The example I always give of this is, A, the bullseye example that you can see on the screen, but B, a broken watch. If you have an old school watch with hands and that watch is broken, or has run out of battery, that's a very reliable watch. It says 3:15 every single time you look at it, but it's only valid twice over the course of the day. So we want to, again, make sure that we are getting both of these pieces. There are two ways, broadly speaking, to assess for validity. One is construct validity and one is criterion validity. Construct validity means we are comparing one measure of depression against other measures of depression. So if I'm writing a new measure of depression for college students, I should be able to give those same college students previously established measures of depression, like the DAS or the Beck Depression Inventory, and all of the measures should agree. If my measure is telling me that you're depressed when these established measures are telling me that you're not depressed, that's a problem. That's poor construct validity. Those measures are not agreeing with one another. Criterion validity means that the measure should reflect what we know the construct to be. So I should be able to sit down with my new measure of depression and the DSM criteria for depression, and I should see that there are similarities. Like, my measure of depression should not be asking you about I'm trying to think, like your video gaming habits or something that is not related at all to depression or loosely related. It should be asking questions relating cleanly to the symptoms and types of impairment that we see from things like major depression. In addition to picking measures that are standardized, reliable, and valid, we also want to take developmental age and cultural considerations into consideration. So, for example, we wouldn't give an adult measure of an intelligence test to a child. The WAIS is standardized, it's reliable, it's valid, but if you're giving it to a kid, then that doesn't make any sense. We also want to take culture and language into consideration. So ideally, we want to make sure that measures have been written in the language that we are using them in. Second choice would be a translation, but depending on the languages that we're talking about, sometimes things can be lost in translation. So we just want to be cognizant of language, but also things like culture. When I was a graduate student, I began doing intelligence tests at the psychology clinic, and I remember one of the clients I was working with was really, really bright. She was another grad student from a different department, but she was from Switzerland. I was like, what country was she from? She was from Switzerland. And she was just knocking me out of the park. She was above average, at least, on every single measure that I gave her. She was very bright, very intelligent. But then I got to the general information section, and a lot of the questions, because this is a measure that was written in the United States, were things like, who was Sacagawea? Who was Martin Luther King Jr.? These are questions she wouldn't have learned the answer to in Switzerland. They are very American centric. And so she did really poorly on this one section, not because she wasn't intelligent, but because these were very culturally specific questions. And so I use this as an example because you might think that, the United States and Europe are more similar. So there might not even be a difference if you were giving an assessment written in the United States to someone from Western Europe. But even in that scenario, you can still kind of stumble across culturally inappropriate types of questions. We obviously want to consider physical limitations as well. So we wouldn't give someone who is blind a visual type of measure. We would give them a more auditorily based measure. And we wouldn't give someone who is mute a measure that would require them to respond verbally. We would give them more of a nonverbal assessment. So ethically, we must choose not only psychometrically sound measures that are standardized, reliable, and valid, but also ones that are appropriate to the needs of each client. Diagnosis then is the goal of assessment, and diagnosis looks a little bit different person to person. Sometimes diagnosis is determining a disorder or series of disorders that a person has. Sometimes diagnosis is arriving at Z codes that describe what's going on. Z codes are kind of cultural codes that indicate things that might be the focus of treatment, though they're not formal disorders. So we might be working on a parent-child relational problem. The child and the parent might not have diagnosable anxiety or depression, but a relational problem certainly warrants clinical attention. So sometimes Z codes are what we end up diagnosing. Sometimes we end up diagnosing things like culture-bound syndromes. Culture-bound syndromes are disorders that exist outside the bounds of the DSM. So the DSM, as I'll mention here in a little bit, is an American manual. And so a culture-bound syndrome would be a disorder that exists in another part of the world, like attacta nervios existing among the Latinx population, but not something that's existing readily within the United States. And so it's considered to us to be a culture-bound syndrome versus a full disorder that is occurring readily within the United States. Some things to consider in making diagnoses are developmental trajectories. A developmental trajectory means that a disorder looks different sometimes depending on how old a person is. So for instance, we might see more anger from a child or a teenager with depression versus an adult. We might see more sadness from that individual. So it's important to know whether or not a disorder looks different at different ages. It's also important to look for sex or gender differences in presentation. So it's more common to see women isolate, become tearful when they're depressed, but with men who are less socialized around emotional expression, we might see men turn towards substance use more so, or anger, when in fact the real problem is depression. We also need to take into consideration the role of culture in terms of what's abnormal. So focusing not just on what's abnormal per the DSM, but what is abnormal and what isn't per that person's specific culture. And then based on all of that information, we, again, determine whether or not there's something there to label or not. And we make these labels on the basis of something called the DSM, which I've referenced over the past couple of class periods. The DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. We're currently on the 5th edition. And as you guys can see from this slide, it's written by the American Psychiatric Association. And that's important for two reasons. One, American. So this is an American manual. It is not a universal manual, although it is used in other countries. And two is psychiatric. So this is written by medical doctors. The difference between a psychiatrist and any other mental health professional is that the psychiatrist goes to medical school, which is why they can prescribe. And so that's one of the reasons that we use a very categorical black and white approach to diagnosis, where we've got a label, something like major depressive disorder, and then we've got a series of symptoms beneath that. Many biomedical conditions are categorical in nature. For instance, you are pregnant or you are not pregnant. There's not a lot of middle wiggle room there. But as far as depression goes, there's a lot more gray. You know, if someone only has 4 symptoms, but this manual tells us we need 5, that doesn't just magically mean that this person's not depressed and that they're fine. There still is something going on there. And so this categorical way that we diagnose things exists more so because of the folks who wrote this book than because this is a good way to look at mental health. Some advantages to a categorical approach are that it does give us a common language. So when I say major depressive disorder, we all know what that means. Another kind of piece to the categorical approach is that mental disorders are thought to be discrete, meaning we've got this diagnosis over here and this diagnosis over there, and they are separate from each other. They are unique. However, one of the things that's happened over the years is that we have acquired a larger number of disorders as time has passed. So in 1952, when the first edition of the DSM came out, we had 106 disorders. And these were relatively discrete things, things like schizophrenia versus a bipolar disorder versus a borderline personality disorder versus a depression, things that were unique and worked a little bit better given the categorical approach that these disorders kind of exist within. But in 2013, when the DSM-5 came out, there were 237 disorders within the book, and that doesn't include things like culture-bound syndromes or Z-codes or things that are provisionally listed in there. That's just full-fledged official disorders. And so one of the things that's happened with time is we now have more than double the number of disorders we had to start with about 60 years ago. Is there's a lot of symptom overlap between different disorders, which leads to more time spent on differential diagnoses and more people emerging with what's called comorbidity. Comorbidity is when a person's been diagnosed with more than one disorder rather than just one. So because we have so many disorders and we've kind of run out of like mental health real estate is how I like to describe it. We just have more people who have multiple things going on because they happen to have a constellation of symptoms that multiple labels describe well. An alternative approach that we could potentially use is more of a dimensional approach. A dimensional approach, rather than looking at disorders as labels with symptoms and you're either in that category or you're not, instead is going to stretch symptoms out along dimensions, which allows space for people to kind of fall in all of those gray spaces and just kind of fall where they may. So to highlight this a little bit more, I'm going to give you some examples relating to the mood disorders. So categorically speaking, there are 5 big mood disorders. We've got major depression, dysthymia, bipolar 1 and 2, and cyclothymia. Major depression is acute in nature, but it's more severe. Dysthymia is more chronic and it's milder. Bipolar disorder entails both depression and mania, and it's acute. Bipolar 2 disorder is also acute and it entails depression and hypomania. And cyclothymia is more chronic and has milder symptoms as well, kind of like how dysthymia is chronic and a bit milder. So these are all very specific categories. And again, you either fall into one of these categories or you don't. Very black and white way of thinking. Dimensionally, though, depression, hypomania, and mania exist on a spectrum. Depression is clinically low mood. We've got normal mood in the middle. And then mania and hypomania are going to be more extremes of joy and more positive emotion. And then from a duration perspective, we could also stretch that out along a dimension as well, tracking everything from extremely long-term, very, very chronic to very acute, maybe only lasting a couple of days or maybe even a couple of hours. And the nice thing about a dimensional approach is that this encompasses everybody. You could even describe a healthy person using these dimensions. A healthy person would have normal mood, and that normal mood would be chronic in nature rather than just temporary. So dimensions can accommodate everybody. Versus categories can only accommodate so many different types of people. Here I'm describing 5 types of people. On the previous slide, I noted that the DSM-5 describes 237 types of people. So I've talked about a couple of the pros and cons of each approach kind of throughout this lecture. I'm not going to go into the pros and cons in greater detail. I want you guys to kind of reflect on what you now know about categories and what you now know about dimensions, and just list out what you view the pros to be, what you view the cons to be, and we'll discuss this more in class. So things to look forward to for the next class period include debriefing this particular exercise, discussing the pros and cons in greater detail, and I'll also be showing you more examples of different screeners, assessments, and outcome evaluations, just so you have some visual types of examples to go with the descriptions of the different measures that I gave you today. All right, that is all that I've got for you guys. See you next time.